Hi, everyone. My name is Gabriel Altit. I'm a neonatologist at the Montreal Children's Hospital, and today I'll be presenting on the hemodynamics of bronchopulmonary dysplasia, heart and lung interactions, as well as pulmonary hypertension. And this is given in the context of the BPD workshop at NeoHeart 2025. So it's really a pleasure for me to be part of this and a privilege. And I would like to thank the organizing committee, specifically Dr. Shazia Bhombal, who's leading this workshop, for inviting me to present on this topic. So these are my current disclaimers. Most medications discussed have not been tested in the context of RCTs in the newborn for BPD-PH, and Mallinckrodt supports the NeoCardio Lab through an unrestricted educational grant. And so at the end of this presentation, the participant will be able to outline some of the pathophysiological phenotypes of pulmonary hypertension BPD patients and discuss a bit of the management strategies, and all of this within 15 minutes. So this is pretty much the picture of a patient with bronchopulmonary dysplasia who presented with suprasystemic pulmonary arterial hypertension. And so BPD is a quite complex condition of the lungs, the pulmonary vasculature, the airway, and the pulmonary veins, and the pulmonary arteries and capillaries and lymphatics. And so this is really the picture we're trying to avoid in the context of BPD, as you can see in this particular condition or patient phenotype. There's a really dilated, dysfunctional right ventricle that is pancaking the left ventricle, probably with some degree of low preload of the LV, and suprasystemic systolic RV pressures. And so one of the questions we always have to figure is what exactly is the definition of pulmonary hypertension. Hyper means high, tension means blood pressure. And so it's really the high blood pressure in the pulmonary vasculature. And this can be secondary to various etiologies. And so what we're trying to outline in these patients is whether or not there's high pulmonary pressure in the pulmonary artery, with the end organ damage often being the right ventricle, with eventually low preload to the left ventricle, which leads to poor LV output, and in terminal cases, a cardiac arrest. And so if you are familiar, we're talking here about most commonly group 1 pulmonary hypertension, which is pulmonary arterial hypertension, which is a bit of a misnomer because they're all with high arterial pressure in the pulmonary artery, but what we mean by pulmonary arterial hypertension is often due to secondary high pulmonary vascular resistances. And this high PVR can be secondary to either vasoconstriction or decreased pulmonary vascular surface area, or abnormal pulmonary arterioles that lead to a heightened condition of vasoconstriction, or a decreased intraluminal capacitance of the pulmonary arteries. We can also have what we call sometimes the post-capillary phenotype, or group 3 pulmonary hypertension, where you get venous congestion. And this could be because of LV disease, mitral valve disease, pulmonary venous disease, or a combination of all of those, or kind of a restrictive phenotype of the left ventricle. This is often something that is seen in adults, for example, when they have left heart failure. And then you can have sometimes other conditions like obstructive conditions like pulmonary embolus, or multiple embolies or shower embolies throughout the pulmonary vasculature, leading to some degree of obstruction. Sickle cell disease could sometimes present like this. And then we have the categories we deal with in neonatology, which are often this multifactorial conditions in which BPD sits, where there's a component of high PVR, there's probably a component of venous congestion, and there's obviously a component of decreased pulmonary vascular surface area with remodeling. And so really the definition of pulmonary hypertension is high blood pressure in the pulmonary artery, but we did establish as an international community cutoffs, mostly using cath-based evaluation for the diagnosis of pulmonary hypertension, where we will classify a patient after the age of 3 months at sea level with pulmonary hypertension if their mean pulmonary arterial pressure is 20 millimeters of mercury or more. And this number has been associated in pediatric adult cohort with adverse outcomes such as mortality and lung transplantation, mostly in population of patients with idiopathic pulmonary arterial hypertension. But we use this cutoff to establish the diagnosis of pulmonary hypertension. And so we will often use a systolic pulmonary arterial pressure around a value of 40 millimeters of mercury in the pulmonary artery to classify these patients using echo as quite concerning for the presence of pulmonary hypertension, knowing that by echo, it's much more difficult to quantify mean pulmonary arterial pressure. And we often get estimates of systolic pulmonary arterial pressure or systolic RV pressures. And so these cutoffs are obviously after the natural drop of PVR in the postnatal transition. And so for the first 3 months, there's still this, very important transition where the PVR dropping and SVR increasing and the RV is remodeling in this extrauterine environment. And so usually we have normal PA pressures around 15/5 with a mean of 10 after 3 months of age. But before 3 months, we may have higher PA pressure because these PVR are still doing the transition. And I do want to remind you that, a pressure is a component of resistance times flow plus the distal draining pressure. And so when we're looking at pulmonary hypertension, we're obviously trying to decipher what are these components that are being impacted. Is it the resistance? Is it the flow? Or is it the distal draining pressure or combination of all of those? And so we'll often speak about pulmonary arterial hypertension or this pre-capillary phenotype when there's a heightened level of PVR, whether it is reactive, such as sometimes seen in BPD, or fixed because there's vascular obliteration or vascular hypoplasia, decreased surface area, which is also something we can see in BPD. And then you can have a rise in pulmonary pressure because of this increased PVR, especially if you maintain, which is the goal, is to maintain the flow so that you don't drop the cardiac output. But we can also have a component of venous congestion where these patients may have either left ventricular stiffness or high LE pressure secondary to mitral valve disease, or mostly issues with the pulmonary veins, which leads to a component of pulmonary venous hypertension, which we sometimes call post-capillary group 2 pulmonary hypertension. And so we said, why is the BPD affected by pulmonary hypertension? Where, if you look at the older classification, it was its own classification of pulmonary hypertension, the pediatric pulmonary hypertension system. And so why? Well, because prematurity has immature lungs. They're exposed to many injuries of the lungs, whether intrinsic or genetic predisposition or fetal environment or everything that we do to keep these patients alive. They get a lot of inflammation. They get a lot of pulmonary vascular disease eventually because of abnormal vascular pruning and remodeling, decreased surface area. And the problem is that they can have a lot of heterogeneous lung disease. And this is true for the vessel too, where you get areas that have normal PVR, but others that have increased PVR, other areas that will be, with venous problems or lymphatic problems. But the good news is that these patients tend to get better as the lungs are getting better. So the idea is to protect these lungs and make sure that these lungs are growing appropriately with the least amount of injuries, including the parenchyma, the airways, or the vasculature. And so we often talk about the trifecta of premature lungs, which impact airway, parenchyma, or vasculature. I think we're going to speak a lot about this in the workshop today, so I'm not going to go over all of this. And so it is quite a complex disease because you'll need to tackle all of these aspects if you really want these arteries to drop their pressure and eventually preserve the RV from remodeling and from impacting the outcomes of these patients, because we know pulmonary hypertension is associated with increased mortality. So it is important to better understand the cardiac performance in these patients when you suspect pulmonary hypertension. As you can see in the era of screening, there's a strong recommendation to screen for pulmonary hypertension in these patients with BPD using echo. And the severity scheme is mostly based on how this RV is behaving in this context and whether or not you have signs already of severe RV hypertrophy, RV dilatation, or RV dysfunction to classify these patients within the moderate or severe zone. I've put here a QR code of what we do in our center. We've designed this in a multidisciplinary fashion, and so I do highly recommend you do the same within your own center, but I've put there what we do in our own screening process. We have a process where we will evaluate all patients under 30 weeks. And the reason is that in our population, these are the patients that we've seen are more at risk of developing significant PH. And so we will screen earlier if there are additional risk factors, like being born extremely preterm 22 to 24 weeks, being born IUGR, or still being on invasive ventilatory support at 32 weeks or deemed symptomatic. But otherwise, we will do our screening at 36 weeks and then categorize whether they have or not pH, and then if they have pH, if it's mild, moderate, or severe, based on cardiac function and other properties of measurements on the echo. And so we will consider patient to screen in room air if they have a birth weight corresponding to IUGR. So the timeline, as I mentioned, is at 36 weeks. Here are the considerations for earlier screening, and the cutoffs that we use is obviously if we can get a pulmonary insufficiency jet, which provides information in diastole, and we have values of PA to RV gradient of above 20 millimeters of mercury, then we will tag this patient as likely with pulmonary hypertension, or if we have signs of increased systolic pulmonary arterial pressure. So we use a cutoff of 40 millimeters of mercury, which is basically a TR jet of 35 or more, plus an RE pressure estimated at 5. Or if we have a PDA or VSD and it's bidirectional right to left, we would consider this significant for pulmonary hypertension. Or otherwise, if we have a flattening of the interventricular septum or an eccentricity index above 1.3. So these are some of the markers that I've mentioned. So here we're trying to get information about the mean arterial pressure, which is often using the pulmonary insufficiency jet because it's in diastole that the pulmonary valve is closed. And so by continuous wave Doppler, you can get a gradient between your MPA and your RV, or we get metrics of systolic pulmonary arterial pressure, which will inform us on whether or not there are increased RV systolic pressure and increased pulmonary vascular pressure. And then we look at the phenotype and deduct whether it is flow related or resistance related. So this is just an example of cross-sectional view of the RV-LV relationship, where you can see their septal flattening of different degrees up to the point where you get a very significant RV dilatation, hypertrophy, and LV pancaking. This is quite severe and likely suprasystemic RV, but we'll always look at what's happening on the systemic pulmonary, systolic systemic blood pressure side to understand the relationship between both. And this is how we classified our pH severity scheme. So here, no pH, concern for echo signs of pH. And then I'll show you the mild, moderate, and severe. So this is mild, moderate, and severe with various metrics that we adapted from the PPHNet guidelines. So an example of mild, here we have a round septum, crescentic RV, the TAPSE, which is a marker of RV function, it was within normal, but you can see that the TR is slightly above the cutoff at 35, which tells us that we're about, a third to half systemic in this particular patient, but with normal LV RV function. So we would consider this a mild. A moderate here, where we have an RV RE gradient around 70, so closer to the 2/3 systemic to isosystemic, a bit of the flattening of the septum in systole, but otherwise preserved RV function and size. Here we always Doppler the 4 pulmonary veins at each echo because we know that these patients are at high risk of acquired pulmonary vein stenosis. And then here is severe, where you see this pancake LV, very globular RV, with septal bowing. We get an RV dilatation with depressed RV function, and then values that are iso to suprasystemic in this particular patient. Flow related, this is a patient at 36 weeks who had still a generous PDA that was left to right, which obviously will pressure and flow transmit to the pulmonary artery because it connects the PA to the aorta. And so we can see that there's a bit of flattening of the septum. We see that the RV systolic pressure by TR jet are quite high. And we can see that there's still this kind of unrestricted pattern of the PDA and high, pulmonary insufficiency jet velocities. And this is an example of the loss of the biphasic triphasic pattern of pulmonary veins with a high mean gradient here, which is estimated at 12 millimeters of mercury, so well above the 3, concerning for pulmonary vein stenosis. So in our protocol, if we have mild pH, we'll follow a month later. Moderate pH, we follow about 1 to 2 weeks. And severe pH, we kind of meet a multidisciplinary team and start right away to do intensive follow-ups plus management. And so if there's no pH at 36 weeks, we only will repeat at 40 weeks as we're still on oxygen arrest support. And if the patient was not screened at 36 weeks but has new onset oxygen arrest support, then we screen. So our management is obviously BPD prevention is key. Usually there's no lung disease, there's no pulmonary hypertension. That's the kind of usual message, although this rarely is not true in some particular patient where there's really not much BPD, but then they can still develop some pulmonary hypertension. But in general, it's patients with BPD that will develop pulmonary hypertension. And really the focus is not on acting solely on the resistance profile of these lungs, because as I just told you, it's a multi-level mechanism and high PVR is only one aspect of it. And so we actually aim for saturation above 92% in these patients for more than 95% of the time, and we'll often provide supplemental oxygen to avoid hypoxemia because hypoxemia can lead to vasospasm. We get an airway evaluation to make sure there's no signs of airway disease, obstruction, subglottic stenosis, things like that, that would lead to CO2 retention and low pH, which can worsen our pulmonary vascular resistances. We would internally manage a lot of the reflux and aspiration risk while optimizing nutrition, which means having a nutritionist involved and avoiding overfeeding or underfeeding these patients. Locally, although the evidence is quite weak, we do start a trial of 2 weeks of hydrochlorothiazide and spironolactone because there's some evidence that it may impact the pulmonary vascular resistance profile of these patients, and also helps unload a bit of the RV and may also improve the afterload of the left ventricle, which may improve diastolic filling pressures. We involve a lot of the parents into that. So we explain pulmonary hypertension. We talk about pH crisis. We provide some of the PPHNet forms that they have on their website for families. And we do promote vaccination infection prevention for all the family, including the siblings. Other investigation, we do consider them in some of the moderate to severe cases, especially if they behave a bit unusually. We will consider sending a TSH repeat, do a baseline ECG, NT-proBNPs. We might involve respirology to do an overnight oximetry in these patients to make sure they don't have like micro desaturations. We'll often have ENT and OT to involve feeding patterns, especially if they're starting to feed orally. Sometimes we'll involve genetics if they behave a bit out of the usual. And then we'll often have also MRI and CT to evaluate the pulmonary veins, as well as a cath if we get to severe profiles. So when do we do cath? Obviously, pulmonary vein stenosis concerns, evaluation of shunt contribution if there's a PDA or large ASD, VSD. If we're worsening or not improving despite ongoing management, if at any point we were suppressed systemic, once we introduce some rescue therapy of the right ventricle, and if there's any concerns for LV functional alterations or left-sided disease like flash pulmonary edema, especially when introducing pulmonary vasodilators or LV hypertrophy. I'm not going to go into the left-sided cardiac disease, which can be a contributor. We know these patients are exposed to steroids, coronary steel, adverse systemic vascular resistance due to AKI and chronic kidney injury. And so sometimes we may need to consider that there might be a component of LV diastolic dysfunction. And so they might be exposed to beta blockers or ACE inhibitors, depending on if that's confirmed on the cath lab assessment. Or if you have significant left to right ASD shunt with high velocity there. So INO and pulmonary vasodilators are really reserved for the rare situations where you have either a pH crisis or if you have worsening pH despite all your attempt to improve respiratory conditions. And so our first line locally is sildenafil, but I know centers that will prefer bosentan. This is just the first line for us in Canada at our center because of our experience. It's very rare where we'll use sildenafil. In our center, it happens maybe once or twice per year max, because most of the time these patients will get better with all the other interventions to improve their lung disease. And really, before adding any kind of other secondary therapies, we would consider a catheterization study. And all of these would be made as a decisional process involving a multidisciplinary team. So I've put here basically when we would start these treatments. You see here mild, moderate is mostly the diuretics trial with oxygenation improvement and ventilation improvement. And then if it's severe and you get RV dysfunction, that's when we start considering INO diuretics plus or minus some degree of RV support or even sildenafil in these particular patients. I've put here a beautiful image by Dr. Satyan I've added some of the mechanism of some of these medications. This is for your reference. And so in conclusion, extreme premature babies with BPD are at high risk of PH, and these patients should be considered for a screening by echo at 36 weeks to evaluate both estimation of pulmonary pressure and the phenotype as well as the underlying RV function. And then, it is a multi-etiology condition, and so it does require a multidisciplinary approach to this condition for treatment and management. And so I do highly recommend that you sit down with your respirologist, cardiologist, neonatologist, OT, ENT, nutritionist, pharmacist to kind of establish your own pathways. I just share what we've done locally and at the scale of our TNECO Quebec collaborative. And so don't forget that this is a lifelong disease and these families needs to be involved from the get-go to understand the condition. I've put a lot of resources on the website, so you're more than welcome to look, read, and reach out to me if you have any questions or comments. Thank you for inviting me, and I wish you a wonderful NeoHeart conference.